Embarrassing. Okay, so I'll be talking about the principles for treating a patient of low vision aid. So we should remember that there are mainly 3 principles. In addition, there is a 4th one also. But firstly, so the first principle that we'll be talking about is refraction. We need to know what kind of a patient, what kind of a BCVA we are dealing with before we provide any sort of rehabilitation. And to our surprise, 10% of the cases who present as visually impaired get corrected with refraction. The second principle is mainly of magnification. So it's as simple as the word is, if you can't see, either you go close or you increase the size of the object. Then the third and the most important principle is illumination. So I'll be discussing about these a bit later in the presentation. Fourth thing, which is also important as a part of illumination, is considering the management of glare as well as enhancing contrast sensitivity. So we correct refraction by using glasses for distance and near, and like I said, it corrects 10% of the cases. For magnification, we basically use telescopes and magnifiers, CCTV cameras, and large print software devices. For correcting contrast and illumination, it's as simple, you have a dark against light or light against dark, like as in the case of our PPT itself. It's pretty clear if you can see the white ones better than the yellow ones, right? So coming to refraction, as you can see, whenever you refract a patient with low vision, we should not use a phoropter to take out his best corrected visual acuity. We should use large frame glasses. So after giving a proper refraction, so the advantage is that it increases the visual acuity to create a very sharp retinal image. Coming to the next principle, which is magnification. As you can see on this graph right here, so the visual acuity, the further you go away from the fovea, the visual acuity tends to decrease. So what we do is we take advantage of this fact in cases of people with central scotoma or where the fovea is involved. So we try to magnify the image so that all the light that falls on this temporal or peripheral, basically the peripheral retina. So whatever little cones are there, we take advantage of those cones and we try to use it for the patient to see better. So basically, in short, it increases the spread of the image to look around the central scotoma, as you can see here in this. The downside of this is that it decreases the span of comprehension, and it won't be applicable for cases of where there are peripheral degenerations, for example, retinitis pigmentosa. This is another example of, as you can see. So there's a nice flower, but a patient with low vision cannot appreciate it. So the more you magnify, the better the beauty of the flower that the patient can appreciate. So basically, it creates a blurred, imperfect, yet functionally useful image for a patient with low vision. Coming to illumination. So now, as you know, in cases where there is aniridia or albinism, where there is lack of melanin, so there will be a lot of glare in those patients. In such cases, we need to minimize his illumination or the light settings around that patient or his working space. In cases of glaucoma or pathological myopia or aphakia, we need to enhance the illumination so that we can use the residual cones better. Coming to contrast enhancement. So contrast sensitivity is the ability to distinguish an object from its background. For people with no problem in their eyes, we don't really mind what the contrast of anything is. But for a patient with low vision, his spatial orientation and his daily living skills are dependent on this very aspect of treatment. As you can see here, this is the image on the lower half is the poor contrast, but on the top half is the better contrast. So the patient can appreciate this, like if you use a white against a brown, the patient can appreciate cutting the vegetable, as in this case, much better than this. Now addressing the same thing at home. So as you can see, if you put milk in a white utensil, or if you put water or oil in a black utensil, the patient won't be able to see. So you need to switch such things. Like for example, if you put milk in a black utensil or any sort of oil in a white utensil and you use it for cooking, that's helpful. Similarly, other examples like serving the food on the plate where, white against black, black against white, or any other color which has dark and light contrast. Another thing is that the surroundings of a patient with low vision should not have patterns or multi-colored surroundings so that it becomes difficult for them to distinguish. And even, as you can see, the flooring should have contrast lines. So there are certain diseases which can be treated with low vision aids, and there are certain diseases which cannot. Common ones that we see in our OPDs are usually AMDs, myopias, albinisms and iridias, and optic atrophies. Now, the diseases which cannot be treated with low vision aids are mainly hypertensive retinopathies, diabetic retinopathies, CRAOs, CRVOs, advanced glaucomas, where the retina itself is damaged in toto. I'd hand over to Dr. Ghulam Ali Kamdar now for the presentation.